I'll take over a company on their benefits, and it is mind-blowing sometimes what we find on the back end as far as like where dollars get hidden and where broker compensation gets put. So not every broker out there is horrible. You've got some really awesome people that genuinely want to help their clients, but you also have just things that are not correct.
Good morning, HR. I'm Mike Coffey, president of Imperative, bulletproof background checks with fast and friendly service. And this is the podcast where I talk to business leaders about bringing people together to create value for shareholders, customers, and the community. Please follow, rate, and review Good Morning HR wherever you get your podcast. You can also find us on Facebook, Instagram, YouTube, or at goodmorninghr.com. And joining me today to discuss 2025 trends in employee health benefits is Kelly Baringer. Kelly is Vice President of Employee Benefits Consulting at USI Insurance Services. She's also a volunteer leader with Dallas HR and the HR Southwest Conference. Welcome to Good Morning HR, Kelly.
Thanks, Mike. I'm so pumped to be here.
So we're in the second quarter of 2025, and a lot of employers are already thinking about their annual employee renewals. According to the Organization for Economic Cooperation and Development, OECD, the U.S. pays 25% or more in healthcare per capita than other developed countries. So you're a vice president for a large, well-respected insurance broker, and if you ever go to a dinner party, I'm sure you're asked, why the hell is our healthcare so expensive?
Yeah. Our system is so broken, and it's so frustrating for employers and for employees, right? If you're stuck procuring benefits on the behalf of your employees, you kind of see behind the scenes as far as just how crazy that whole process is. And when you look at the bloat in our system, it can get you really fired up and frustrated. And I'll try not to use acronyms. I'll try to break it down because I know we've got varying levels.
I spent my whole HR career running away from comp and benefits. So you've got to make this really simple.
I'll try my hardest here. But, especially pharmacy today, we know that those costs just keep creeping up and up. And I mean, part of it is the innovation that in the US that we're able to drive. But the other part is just the bureaucracy and the layers of the system and the lack of transparency that we have to deal with. And part of that is why we see costs just continue to drive up and up and up. And we know that some of our carrier partners, they have to make their goals in terms of shareholder benefits, right? But at the same time, America keeps getting sicker and sicker. And we know that from the statistics. We know that obesity is rising. We know that diabetes is rising. We see these blockbuster drugs that, are effective in some cases, but in other cases, are they the best option?
We're not good at changing our own behavior in America.
100%. 100%. And so that's, for me, looking at health insurance, some of the things that we could do to get in front of that and be preventative, we just aren't looking at it from an insurance standpoint, but we really could benefit from some behavioral health trends. But anyway.
Well, I'm sure we'll get into GLP-1s at some point in the next half hour. But so employers are constantly trying to figure out, how do we bring our healthcare costs down? How do we get better results out of whatever we're paying for healthcare for our employees? What are the strategies right now that employers are trying that seem to be getting traction and maybe some success?
Well, I'll share just kind of some of the updated things that we're seeing within insurance. And I don't know that all of these are getting talked about as much as they could be, because I think as brokers, sometimes what we see in our industry is that people are so focused on, this is how it's always been, right? So they're not always looking at what's new out there. And they're certainly not comfortable talking to their clients about it, because talking about the new thing and other updated strategies is a paradigm shift. One of the things that we're seeing happen a lot in the industry is value-based care or directed networks. And so UHC is one of the cutting edge. So there's really, in our market, and really across the U.S., there's really 4 primary carriers, right? You've got your BUCA. We use the BUCA acronym, Blue Cross, United, Cigna, Aetna, as the primary networks that we see for private companies to use, right? Because there's other networks, but that's Medicare, and that's not really what I specialize in. So United is the one that's kind of cutting edge in really pushing the value-based care across the finish line. So they bought a company called Bind a few years ago. And what these plans do is it's an app-based plan. So it's something on your phone or on your browser. So let me talk about UHC first, and then I'll kind of talk about the other carriers, because I think that this is really not something that people are aware of, right? So these plans are driving care based on a care rating that you can search by facility, you can search by provider. So say you need a primary care provider, an OBGYN, or a vascular surgeon. You can search by that particular specialty and see how these doctors, because we know the insurance companies have a ton of data, right? But they're not always willing, or there's political reasons that they might not share that data. But these new overlays are using that information to steer care to providers that have the best outcomes. So
that makes sense, right?
It makes sense, but that's not traditionally how our health system has worked, right?
Well, it kind of goes back to with the Affordable Care Act, all the criticism President Obama got for you can keep your doctor. Everybody wanted to keep their doctor. And when I change insurance, I want to keep my doctor.
Sure.
But that may be because I have rapport with the doctor, or I've been going to that doctor for 15 years. But maybe that doctor's outcomes, or maybe I was born at Harris Methodist downtown, and by golly, when I have my heart surgery, I want it to be at Harris Methodist downtown, that kind of thing. Nothing wrong with Texas Health Resources. I was in my HR career at Texas Health Resources back in the 90s. They try to forget that. But we have those preferences, and consumer preferences are based on relationships often, and not outcomes. So if you're trying to drive people, and I mean, PPOs were really, as I understood it back in the day, a preferred provider. I mean, there was a reason you were going to this network of doctors, but it seems like that's gotten out of hand now.
Yeah, it's interesting to kind of see the evolution of these networks and the carriers. And to your point, the PPOs, I think it's 97% network penetration now. So is it really a preferred provider, or is it just like, the biggest and the most, and, which is fine if that's your strategy and you want to be a super paternalistic employer. But if, say, you have all your employees in one location, maybe we need to look at some better strategies that can help drive costs down, but care up. Do we really need this broadest, biggest network across the entire United States when, 1% of the time they might be using that? I mean, I'm just throwing numbers out, but kind of to your point, you've got to look at the whole strategy and where your employees are. But going back to the value-based care, so they're also driving these plans with, it's not just a care rating, but they're incentivizing through copays. So you might have Dr. Mike and Dr. Kelly, and Dr. Mike has a care rating of a 10, and his copay is going to be $35, but Dr. Kelly is, a care rating of an 8, and her copay is maybe $45 or $50.
Okay, so it's just setting tiers. So I can still see my doctor, but it may cost me more out of pocket.
It may cost you. But I think, when you look at high deductible health plans, right, HDHPs, the whole point behind that thought process was to drive consumer-driven care. Well, but did it really, or was it just a way of kind of shifting dollars, and because of high deductibles, are people shopping the way we wanted them to? I mean, you could argue both ways, right?
Well, because most of our interactions are still with that PCP who we're paying the same deductible for every time, right? And so, isn't that pretty much how that? What's the benefit to the consumer to shop if you're just paying it? If you just pay a copay.
A copay, right? Or high deductible. That's a whole, because sometimes you'll go to your PCP and it's like a $250 copay, charge, and you're like, holy moly. So That's why we have to educate people on high deductible plans. You're not actually paying a copay in most cases. That's why HSA is so important, is so that you have that savings account kind of tucked away. And a lot of times we encourage employers to seed that account because you don't want maybe you do, maybe you just are happy that your employees have health care. But if you go to the doctor and you get a $200 PCP bill, you're like, I'm just going for my well check. Well, well checks would be something else. But that's a sticker shock when you're sitting there. But to know you have that HSA kind of, in the background that you're supposed to use for these things, that's kind of the purpose of the high deductible plans. The other thing about high deductible plans that are paired with a health savings account is it's portable. So you can take those dollars with you when you leave that company, that employer.
The HSA dollars.
The HSA dollars, correct. But going back to the value-driven plans and the consumer-driven, so that's true consumer-driven pricing because at least with Cigna, with UHC and with the Surest, they call them Surest plans, you can shop on their app much like you would Amazon or, Barnes & Noble, whatever.
Right.
Wherever you shop.
I don't think there's Barnes & Noble of that. I think it's all Amazon now.
Right. But the purpose is for you to actually do the consumer-driven healthcare, compare providers, compare facilities. The other thing about those is, one, there's no deductible.
Okay.
It's only out of pocket. So the idea is you're paying your copays. The price is the price. So like, for instance, my husband had a surgery last year. We were on the Surest plan. I shopped by facility. It was, I think, $1,750 for his procedure. I shopped to find out which providers operated at that facility and by care cost, and by copay. And we paid that dollar amount, and then that was it. There was no balance billing. There wasn't the anesthesiologist was going to charge this. There wasn't.
Well, that's one of the things that gets people, right?
Right.
There's so many people touch you, and then, a nurse comes along and brings a new bedpan, and there's $150, and
right.
And so you're saying in these kind of plans, all those little things are just rolled into the
Correct.
cost. And so you've got real transparency. I know if I know what it's going to cost me to get this hernia fixed or whatever.
Correct. And you can see, yeah. So the idea is it's consumer driven, it's transparent, there's no balance billing. There's not supposed to be any balance billing. In fact, we actually got a check back for like $400. And I was like, holy moly, where did this? I had to research. Why are we getting this check back? So that is what we're seeing. Surest has really led the way with this. They have a significant number of larger employers that are even on this plan. Blue Cross is the slowest to market to date. We're recording this at the very beginning of March, and we haven't heard USI. We haven't heard yet what they're doing this coming year. Last year, they were planning to compete with these value-based plans, but when we went into kind of renewal season for those 1/1 plans last year, they didn't really have a lot to offer. Cigna has their simple pay plans. It's not as robust in my opinion, but it's definitely meant to compete with the value-based plans. The other thing to note about these is they on average will take between 2 to 6%. I think sometimes they say 4 to 8%. So there's a decrement there just because the plan designs are different and the utilization turns out to be different once these are on. And
so tell me what that 4 to 6% is. I don't understand. The decrement's got too many syllables for me. So what is,
Thank you.
What are we talking about
there? Thank you. So that just a decrease. So when you're looking at your renewal and you're like, oh, I have this plan and this plan like for like, and I got a plus whatever, because it always seems to go up. Well, oh gosh, we want to keep our prices the same. Well, if you look at if your carrier offers plans designs like these, you'll see the decrease.
Oh, okay.
You'll see a percentage decrease. There are overlays that you can do. There are some point solutions, so some other solutions that you can lay over the top of other carriers. So Surest is nice because it's so built in and slick, but the other ones you can lay on top if, like, say, for instance, blue, it's not as slick quite yet, but there are other options that you can use to achieve a similar effect.
Is there a certain size employer that these are really targeting? Like, I mean, if you've got 40 covered lives or 70 covered lives, are you going to be hearing about this from your broker, or is this really larger employers?
It's not larger. It's totally made its way down to the mid-market. I don't work a lot with small group under 50. I think it's available down market, but I'm not 100% sure. But I would say in the space, 50 employees on the plan and up, we're definitely seeing it. But not all brokers are talking about it. There's kind of that, I think I talked about it a little bit earlier. Sometimes you get scared of the new and you want it to be proven out. And so depending on who your client is or who the broker is, they might not be as open to talking about stuff like this. Mm-hmm. I know Surest has been in the market for, I want to say, at least 5 years. So it's certainly newer. They've proven out at this point, but I don't know if everybody's talking about it. So I think sometimes you have to ask about it, unfortunately. So hopefully that answers your question there.
Do these plans address the problems that so many employers are having and so many consumers are having with the cost of prescription drugs? I mean, and I a couple of weeks ago took a deep dive into understanding PBMs, and I don't understand
pharmacy benefit
still.
managers.
Yeah. Oh, thank you. Yes. Yeah. And I still don't think I understand it completely, except that it seems like it's not something that really is
transparent,
managing the benefit cost very well.
It's not. No, PBMs are very much different than what the medical carrier. I mean, so when you think about a pharmacy benefit manager, PBM, often when they're standalone, you're talking about a self-insured plan. Mm-hmm. So depending on how your overall plan is structured, right? If you're fully insured, your pharmacy benefit manager is built in. Okay. And then you get into things like the formulary, right? And the formulary is essentially the prescription drug list that the plan uses to say, this is good, this is bad, this drug is okay for you, this one isn't. And then also within that is, okay, you get into tiered usage, and do I do a generic do I have to start down here? And then will my doctor let me try this next drug, and so on and so forth. So PBMs just get a lot more complex, and depending on how your plan is structured, and that's where, frankly, a lot of the dollars we think are hidden. And when you talk about rebating, there's a whole rebate game that is played, which gets really frustrating. I was talking to a colleague earlier today, and we were talking about how, I think it was actually the GLP-1s, just the self-pay cost was like $400 some, no insurance. But when you get into the insurance game, they sometimes will charge more. And the reasoning is because of this rebate game, because they've got to pass a rebate on here to this other people. And so one of the things that USI does, that my company really tries hard to do, is just get away from that game altogether. And sometimes you can't, right, if you're in a fully insured plan. But if you're able to get to a point, and this is where your broker should really come in and hold the carriers accountable to what they say they're doing. My boss makes a funny joke about how carriers are kind of like high schoolers. Like, if you're watching them, they'll do what they're supposed to do. Yeah. But the second you turn away, like, they're, off in the corner, like, doing something mischievous sometimes. But anyway, I digress. So that's where the rebate game kind of gets funky. We'd like to just steer away from that entirely, and not, because you kind of get addicted to rebates in a way. Like, oh, I got a bigger savings this time. Like, oh, you did so good. Well, maybe if you didn't get it, maybe if we just kept the cost.
They're kind of gamifying
it,
right?
100%, Mike. You're 100% right.
Yeah.
It is a game. So anyway, that is what I'll say on that.
Yeah. And let's take a quick break. Good Morning HR is brought to you by Imperative, bulletproof background checks with fast and friendly service. At Imperative, we help risk-averse clients make well-informed decisions about the people they involve in their business. Because our research is thorough, our reporting is robust, and our compliance is strict, our clients can take action on the information we provide. And when they call us with a question, we answer the phone and get them what they need with fast and friendly service. You can learn more about how we serve our clients at imperativeinfo.com. If you're an HRCI or SHRM certified professional, this episode of Good Morning HR has been pre-approved for 1/2 hour of recertification credit. To obtain the recertification information, visit goodmorninghr.com and click on Research Credits. Then select episode 198 and enter the keyword 2025 benefits. That's one word, 2025 BENEFITS with no spaces. And if you're looking for even more recertification credit, check out the webinars page at imperativeinfo.com. And now back to my conversation with Kelly Baringer. You mentioned GLP-1s, and I was reading USI's benefits summary thing for employee
Market
benefits
outlook.
market outlook.
That's right. Yeah.
And it was interesting because, and I've got doctor friends who are really concerned about GLP-1s, some of the long-term stuff that maybe isn't known
That's
about
right.
what it's going to mean. And certainly it's efficacious. It seems like if you really have type 2 diabetes, but I was reading in the 2025 employee benefits market outlook from USI. And then I thought, well, this is marketing stuff from USI. So let me go check it. And I got on my best friend ChatGPT and started asking questions. And it pointed me to a lot of other sources that said that there's this big uptick in diagnoses of type 2 diabetes. And there's a lot of questions. Do these people really have type 2 diabetes? Or are they just going to their doctor and saying, all the other ladies at the country club have lost 50 pounds and I want to lose 50 pounds too.
That's right.
And they're just getting that diagnosis and going and getting that. Or all the dudes at the bar, are drinking just as much as I am and they've lost weight. So.
Yeah, I have heard things like, you look around the internet and people tell you how to game the system so that you can go get that diabetes diagnosis, so that you can get your GLP-1. And I think you really have to ask yourself and consider, is that the safest thing for me or, your friend or whomever you're talking with? Because we know that and I could be, I don't know that, I'm not confident, but what I have heard is that the average time that people stay on GLP-1s is 6 months because of all the side effects. We also know that diabetes is underdiagnosed. A lot of people, they estimate about 20% of people with diabetes don't actually know that they have diabetes. So I think the GLP-1s are incentivizing people to actually go get tested. But to your point, we have also seen the rise of diabetes diagnoses go up. I forget what the number was, but between 2021 and 2024, we've seen the instances go up. One of the things I appreciate about what we do at USI is we track our own data. And so I love that you went and checked your own sources.
Your data said it doubled. Yeah, your data said it doubled. Yeah, and which shocked me. Yeah,
which is fascinating. But it is interesting because we have our own internal programs, but then we have our whole book of business data set that they monitor. And I don't know that everybody does that. And it's just interesting to see broadly what's happening within that space. The other thing to note on that, and you probably read this, is the FDA's emergency declaration about semaglutides has ended. Did you read this part?
No.
So,
as soon as you start talking about semaglutide, anything.
So that's the GLP-1.
If I have to figure out a definition, my ADHD, I just have to go take another Adderall. Yeah.
So essentially what's going on is we see all these compounding pharmacies that are, cheaper, better, like I've got the GLP-1s, Well, the reason that they were able to do that is because there was a emergency authorization from the FDA back in COVID saying that there was a shortage of the Wegovy, GLP-1s. Well, now that shortage has been declared over, these compounding pharmacies are supposed to stop compounding. there's going to be a bunch of lawsuits because, of course, they're making money off of this stuff. So they're not want to do it. But there's also some concern with the safety of these, and are people getting screened properly and so on and so forth, because they can make you sick, right? If you're not
Well,
doing
and
it
we
right.
saw 15 years ago, it seemed like everybody was getting, and can't think of what the real surgery is called. We always called it the thumb
the lap
stomach.
down.
And you would see people, they would lose a lot of weight real rapidly, but they didn't change their behavior.
Correct.
And then they had a lot of health problems because they had changed their bodies and they were still consuming the same, caloric intake. And so, I think we have to be, just as consumers, we should all be, and employers, as we talk to our client or to our employees, really careful about more fad stuff and make sure things are, but obesity is a giant problem in the US.
Problem.
And like so many things, employers are picking up a lot of the cost here in the, for things like that when they pay for healthcare for their employees. And we're all paying for it, inside the system.
Yeah.
So if I'm an employer and I'm managing my employees' healthcare, what are my fiduciary responsibilities? I know that's been a topic, and I've got fiduciary responsibilities to my employees. I've got some responsibility, I assume, to make sure that what we're delivering is really giving them the kind of care that they need at some level. How does an employer do that? And is it? I'm assuming there are differences if you're self-employed versus if you're doing this, if you're just
self-insured versus fully insured. So I love that you brought that up, because with all the CAA, so the Consolidated Appropriation Act, yes.
Yeah.
So that happened, as well as all of these lawsuits, right? The Johnson & Johnson lawsuit. If you remember a few years ago, when 401k compensation was all over, the HR scene, and everybody was talking about that. So that's kind of what's starting to happen on the benefit side. And what is being requested of human resource people, or just plan sponsors in general, is to be able to point to what is my broker compensation. And if you're unable to do that, which is crazy because it's kind of on the broker to tell you what they're being paid.
Yeah. How would even whoever's purchasing at the company know what the broker's really making money on?
Really, they should. And that's part of the disclosure piece. So going kind of back to what we were talking about earlier with all of the dollars being hidden in different parts of the program, especially when you're fully insured, it's kind of frustrating. I'll take over a company on their benefits, and it is mind-blowing sometimes what we find on the back end as far as where dollars get hidden and where broker compensation gets put. So not every broker out there is horrible. You've got some really awesome people that genuinely want to help their clients, but you also have just things that are not correct and wrong. So for instance, we've seen consortiums where the broker was getting paid $1.25 per script on the back end. And we're like, why is the broker getting paid for this? Just there's places that people hide money.
$1.25 per prescription? Holy cow.
So if you just think about that and how that adds up, and I think this was a company that had about 1,000 lives or so. So clearly when the CFO found that out, he was extremely, it went both ways. He was really upset. I'll use nice words about finding this extreme overcharge because they had been paying this for how long. But on the same token, really happy because, if you think about, and I know I've got some strategic HR people that go, oh, my working capital, I need X to do Y. If I have an extra $20,000, I can put this into my HRIS system or, hire Mike Coffey for some awesome, background check. When you put it in terms of working capital, that makes a huge difference. So that's where the broker the compensation matters. And sometimes we, even as brokers, we don't find out until we start talking to all the the carriers and the vendor partners.
So how does that disclosure made to an employer? I mean, is there like a single piece of paper when I sign up for the plan, it says, here's how the broker's paid, or is it hidden in a lot of places? Or
that's a great question. Your broker should be disclosing that to you. And we are actually doing it as early as finalist presentations before anybody becomes our client, with kind of what we think, just the way that the law is laid out. We're kind of getting that proactive with it. But they should be seeing that disclosure in any report that they have. And it should be something that they can put their hands on. And the reason is because, think about this, like with the 401ks, you're technically a fiduciary of that plan. If something happens with that plan, oftentimes, like say you get sued, they're coming to the fiduciary, AKA HR in a lot of cases, for whatever's wrong. And a lot of times it's on a personal basis. The thing that HR people need to consider, and I don't want to freak anybody out.
The people that are bringing these claims are your own employees in this scenario, right? The people, or at least the people whose money you're managing in the 401k,
Correct.
Or in the case of a healthcare,
benefit plan,
the lives you're,
Yeah. But when you think about your E&O policy, the errors and omission policy, oftentimes that covers the C-suite within a company. But if a VP of HR isn't considered an executive, they're not necessarily covered by that policy. And therefore, their fiduciary obligation isn't covered by the company's insurance. So again, I don't want
your benefits manager or whoever's really making those choices, right? Okay.
Yeah, or whomever. So those are things that you just need to be aware of. So yeah, those I'll leave it there. Those are things that people should be aware of.
So what you're suggesting is that if I have employees who don't think that they are getting their bang for their buck for whether it's their copay or that their insurance isn't delivering, what they should be getting, they can, make the argument that whoever made those decisions didn't act in their best interest when they were choosing those policies. And then there could be some liability for whoever made those decisions. Correct. Or for the company or the entity.
And the frustrating thing is, from my perspective, if I'm an HR person and my broker didn't give me that information to where I can easily say, this is how much we're paying them. My broker didn't give it to me, yet it's on me as the fiduciary to be held liable. Mm-hmm. You see what I'm saying?
Right. Yeah. I mean, you should have asked the questions, right? That would be the argument.
That would be the argument. It just makes me sad because I don't think a lot of people understand that they would be held to a certain standard that they're not aware of.
Right. And I think in a lot of small to medium-sized companies, you rely so heavily on your broker. You don't have expertise in-house on benefits.
You don't have the bandwidth.
And so you're expecting your broker to do this. And so, so listen up, listeners. If you're in that boat, if you're that HR office of, 1 or 2 or 5, and y'all are making those decisions, make sure you're talking to your broker and figuring out, get on my best friend ChatGPT and figure out what you should be asking and get answers.
And I would even go a step further and say, let's have those conversations about how the company, and this is a company by company decision, but how can we protect that fiduciary liability that's placed on the HR person? Do we need an E&O policy to cover those people or persons?
Perfect. Well, that's our time. Thanks for joining me, Kelly.
All right. Thanks, Mike. I think we had a pretty lively discussion.
Yeah, it was interesting. Yeah. And it was benefits and it was interesting. So thank you.
Well, I'll take that as a compliment.
Yeah. One of these days I'll sit you down and tell you some background check stories that'll curl your toes.
Oh,
but
no kidding. All right. Well, thank you so much.
Thanks a lot. And thank you for listening. You can comment on this episode or search our previous episodes at goodmorninghr.com or on Facebook, Instagram, or YouTube. And don't forget to follow us and rate us wherever you get your podcast. Rob Upchurch is our technical producer. And thank you to Imperative's marketing coordinator, Marianne Hernandez, who keeps the trains running on time. And I'm Mike Coffey. As always, don't hesitate to reach out if I can be of service to you personally or professionally. I'll see you next week, and until then, be well, do good, and keep your chin up.